Hello students, this is part 2 of week 2 lecture. So I stopped on slide 12 with the first video. Now I'm starting again on slide 13 with this second video, and we'll see how far we get. I might not be able to get through all of these, but you always have them at your disposal. So another part of supply and demand that we didn't talk about or I didn't talk about in the previous video is that producers are concerned with cost. That's very clear, and those of us that have been in healthcare for a long, long time, you understand when people talk about productivity and how costly healthcare is. So anything that changes the cost of producing a commodity will affect the level of supply. In other words, if it's very, very costly to do something, then generally there's fewer producers that want to do that. A healthcare example might be that a hospital purchases a 3 Tesla MRI. Now, when MRIs first came out, most of them were 1.5 Tesla. That just speaks to the strength of the electrical impulse, if you will, and the strength of the magnet. But technicians, so back to it, but then the industry produced a 3 Tesla MRI. But lo and behold, technicians were in short supply that could utilize the new equipment, and thus demanded a higher salary. So the cost to provide using 3 Tesla MRI versus 1.5 Tesla MRI was higher for hospitals that were using a 3 Tesla MRI. The 3 Tesla MRI as a piece of machinery or a piece of equipment also cost a lot more than the 1.5. So we didn't see a lot of 3 Tesla MRIs, but some came into the market, particularly here in Lincoln. On the other hand, a conundrum for us in healthcare is that the dollars, the DRG, or the dollars that CMS and other insurers were willing to pay for an MRI scan, they didn't care whether we used a 3 Tesla or a 1.5. There was a flat rate for an MRI per chance of saying like an MRI of an elbow or wherever, or total body scans also happens with MRI. But for the producer, the cost was different. So people were careful about, okay, so we can afford a 3 Tesla MRI or we cannot. A huge issue in healthcare which concerns cost is cost accounting. We have direct cost, we have indirect cost, and we have total cost of care. And that's kind of a who knows. And I've read several resources since I've started teaching this class that helps me understand the complexity of cost accounting in healthcare, and we're really not very good at it. So that's part of our problem. That's a concern. And later this term, when we listen to Sick Around the World, it'll be interesting to you to note how other countries handle this condition around cost. I won't give you a trailer or give you too many tips ahead of time, but you'll notice when we watch that video, Sick Around the World, that countries, other health systems around the world handle costs in a real different way than we do here in the United States, and we might have some discussion about that. Well, I want to move on to slide 14 because this is a key slide to understanding this whole concept of supply and demand and the role of buyer and seller and price elasticity, these things that we've been talking about. And I want to use this to help you understand that it happens differently in healthcare than most other industries. So in most industries, we have a buyer and we have a seller. And that's the typical economic arrangement. The buyer or the seller sets the price and says, this is what I need to be able to produce more of product XYZ or service ABC, and the buyer makes a decision about whether they're willing to pay that price or they're going to look for a substitute. So in most industries, we have a buyer and a seller, and it's a straightforward relationship. Well, let's move down a little bit and now put into, on the payer side, we're going to start talking about a chooser. So there is a payer in healthcare, but somebody else might be making the choice. And that seems reasonable to us. The patient or the patient's family is oftentimes involved in making the choice. So we can move down a third level, and then the seller is still on their side. But now we have, we can talk about on the buyer side, the buyer being the patient, the provider, and the payer. All three are buying what the seller has to sell. So we might think about, a total joint replacement. So we have the patient being the chooser, making a decision about what physician they might go to, what surgeon they might select, even what hospital they might select. Then the provider, you have the provider who is the surgeon who's going to put in the total joint replacement, and they're going to make a decision about what device. So now, if the seller is the device company, so the seller is concerned about what the patient wants, but maybe more importantly, the seller is concerned about what the provider, what that surgeon chooses. And now we have the payer, and the payer also may say, well, the last 100 DRGs of this particular procedure, we paid XYZ, and that's what we're going to pay. So the payer also gets involved in the decision making on the buyer side, because if the payer says, no, we're not going to pay, then the patient may say, no, I'm not going to have the procedure. Well, now we get to go one more level in healthcare, and there's times when we have the patient, the provider, and the payer on one side of the equation, and the provider also on the seller side of the equation. And so Joe Flower, that I've used some of his quotes and talked with you about, I think, last week, he makes this statement that this conundrum, so the fourth dot point in this graphic is really saying we have a very complex buyer-seller relationship going on in healthcare. And then he makes this statement: this does not mean that the choice is necessarily wrong, or the product overpriced or unnecessary. It does mean there is a conflict of interest. And we've seen this in a variety of ways. If the provider of the procedure is also is the seller, and the provider of the procedure is the doer, in other words, the buyer, then we end up with a conflict of interest. So that continues to be part of our healthcare industry and one of the economic realities that we live with. Well, let's move on to the competitive model on slide 15. In the competitive model, we have to talk about consumer sovereignty. So what is produced is determined by what people want and are able to buy. We're very used to this in the United States. In other countries, maybe not so much, because they may not have quite the plethora of choice that we have. Firms then become providers. They base their production decisions on relative prices and relative price movements. And there's an equilibrium when the firm's output decisions balance with the consumer's decisions, and overlaying all of that is the impact of price. So in free market enterprise, which we value, free market enterprise seeks to find that equilibrium so that the producers are making decisions about how much to produce, and that balances with the consumer's desire. So then prices signal producers what to produce, and they serve as a means of rewarding popular decisions. So if a producer is producing a product or a service that is not, the consumer doesn't want, or it may be priced too high, or maybe there's better technology, there's many, many things that can impact, but all of a sudden it's like, whoops, the marketplace doesn't want my product, doesn't want my service, so now I'm going to produce less of it. So that's the impact of the competitive model. Perfect competition occurs when we have many buyers and sellers, when we have a standardized product, when there are mobile resources, in other words, there's not a shortage, there's not a scarcity of resources, and we have perfect information. So I took these four issues in terms of perfect competition and tried to look at ACA to see if the Affordable Care Act was trying to stay true to a strong competitive model. Because I think the supposition is that perhaps it was more socialistic. Well, in my opinion, I believe that they really have worked to move us to a more competitive model. Not all countries do it this way, but the competitive model is alive and well, and the free market enterprise, concepts, philosophies, is really what has made America strong and vibrant up to this point. So we like competition. So let's take the first one, many buyers and sellers. Creation and structure of health insurance exchanges. That was an attempt to bring more insurance players, give the consumer more options. There was also consumer-operated and oriented plans. We called them co-ops. They're still alive and well in some parts of the country, but there was one that was working between Iowa and Nebraska, and I think they went belly up. I think that one failed, which that kind of happens. And then federal support for expansion of Medicaid. All of those were trying to get more buyers, more sellers. So think of buyers as patients, sellers as producers, and sellers as part of the payers and insurance company. We were trying to get more of those in the market. And then they focused on a standardized product. There's the national quality strategy. We know of that in hospital language as value-based purchasing. They also came up with an essential benefits package. By law, insurance companies have to provide certain preventative services. So they're trying, and I would say standardization is minimal yet within ACA. Mobile resources, the whole requirement to have coverage. They want everyone to have coverage, and the hospitals quickly picked up on that notion and understood that if we had expansion of Medicaid and everybody with coverage, that we could take some hits in terms of the dollars per procedure that were coming to us because we would have more people seeking those services because they had coverage. And then this requirement to offer coverage, the employers. So that was a way that the ACA tried to mobilize resources, pour more money into the system. Now that seems like, wow, we're already spending so much more than we should be, and that's true. But to make the whole system work and to be true to a competitive model, ACA tried to pour more money into the system. And then perfect information. So we have high tech, that health information technology for economic and clinical health. That's where I said last week that I doubt that ACA could be working in any fashion if Congress hadn't passed high tech in 2009. They passed high tech, passed that bill in 2009, and then we began to, and then passed ACA in 2010. And then out of high tech came this whole meaningful use concept. So again, from a competitive model, we knew that one of our problems still is, and I think in healthcare in the United States, one of our issues is this whole access to information. Perfect information doesn't exist. So now I would like to recommend that at the conclusion of this video, you might go out and access Rachel Botsman, The Currency of the New Economy is Trust. That's a TED Talk. I think you will find her very, very interesting. And there's some questions to kind of guide you as you listen to her. I'm not putting these questions on the discussion board because I would like you to answer the others that I mentioned earlier. But she has very interesting concept around trust and the new economy of trust that I think you will find interesting. Let me move on to slide 18. I'm going to talk about just a little bit about ACA. Actually, I'm going to skip slide 18. It's there for you to read. Let's talk, instead, I'd like to talk about characteristics of the U.S. healthcare system as a whole, and I'm pulling this information off the Kaiser Family Foundation. So there was an August poll, this is August of 2015, on the ACA. And basically what we discovered with this was that the Americans' understanding of Affordable Care Act and how it's impacting their lives, it's closely divided. 44% reported a favorable view of the law and 41% reported an unfavorable view. Now, what's interesting though is that even after, and it carries Obama's name, Obamacare, that Obama got elected for a second 4-year term. And he and some other sources took that as a mandate that the Americans really were okay with Obamacare. Obamacare, the Affordable Care Act, is his signature legislation, really out of the total of those 8 years. There are some other laws that got passed under his administration, but not too many, as we've seen, as we've observed. So the opinion about what Congress should do next when it comes to the law has been fairly constant over time. Equal shares say they want Congress to expand the law, and others say that they want the law to be repealed. It'll be interesting to watch what happens after November, depending on which candidate is elected to the presidency. The other thing we might want to talk about a little bit, and I'm moving on to slide 20, is prescription drugs. Prescription drugs continues to be a problem, a concern. One of you mentioned last week that the EpiPen, I think, Corey, it was you that said the EpiPen had gone up 400%. So 54% of Americans currently take prescription drugs. So there's a high demand for prescription drugs. 72% report prescriptions easy to afford, 24% report paying for their drugs is difficult. So if we even take that 24% and say, wow, what kind of choices are they making? They're not getting their drugs. They're not moving ahead. Consumer support for the policy. We do believe there's consumer support for the following policy changes. Again, my resource for this is this Kaiser Family Foundation. 86% say we need to require drug companies to release information on how they set prices. That would be an interesting one, particularly that EpiPen example. 83% then believe that we need to allow the government to negotiate with drug companies to lower prices for people that are on Medicare. And the federal government is the largest single buyer of prescription drugs. We have Medicare Part D. But it was written into the law that the federal government could not negotiate prices with the drug companies. There was, you can think about that as that would have been antithetical to the free market enterprise. So in the meantime, we have drug companies increasing drug prices at a pretty exponential rate. Back to this little survey, 76% said limit how much drug companies can charge for high-cost drugs for illnesses such as hepatitis and cancer. And then 72% were saying allow Americans to buy prescription drugs imported from Canada. So again, I think prescription drugs and how Mrs. Clinton, if she is elected president, how she'll choose to deal with the pharmaceutical companies will be very interesting for us to watch in the first few months of 2017. I'm coming up on the end of this little video, and there's other additional slides for you to view. Well, we're up to slide number 21. You can take a look at the role of CMS. I thought it would be helpful for us, and I think I do have a little bit more time, so I'll go ahead and just orient you to these two slides. So CMS is a center for Medicaid and Medicaid services. They are responsible for trillions of dollars in annual spending, and they have over 100 million beneficiaries. Now, the total population of America is about 318 million. So Medicare and Medicaid is covering about a third of us. 39% of total health care spending in the U.S. comes from Medicare and Medicaid, comes from CMS, and CMS accounts for 43% of hospital revenues. So hospitals for years have paid careful attention to CMS. You can read the rest of that slide, just gives you a little bit of history. But Continuing on to slide number 22, CMS is the lead agency in Health and Human Services for implementation of ACA. That's something that not a lot of people know about, but they are. They oversee new insurance marketplaces and healthcare.gov. They created the Center for Consumer Information and Insurance Oversight. There is another center called Center for Medicare and Medicaid Innovation. We've seen some very interesting demonstration projects come out of the Center for Innovation. And then quality goals that were announced in January of 2015. They are shifting 50% of Medicare payment to quality and value by 2015. So that's a major shift, and shifting 90% to quality/value by 2016. That, I'm sure, is having a huge impact on all of our hospitals and other providers. My guess is all of our physicians, whether they're in independent private practice or employed, are also getting a very healthy dose of that. The final slide introduces you to another TED Talk by Arthur Brooks. Arthur Brooks is an economist. He is a conservative economist, but he presents a very interesting plea that we all open our minds to each other, to diminish the polarization, so that our conversations really can bring about the most good for the most people in our society. Thank you for listening. With that, I'll end this lecture.